Good evening, everybody. We'll give it a couple more minutes for any late arrivals. Okay, I think we'll get underway if that's okay with everybody. Hopefully you can hear me okay. I'm delighted to be a co-host here tonight together with my colleague Mike Barrett. My name is Alex Hector. I'm the Executive Director of the Southeast Grey Community Health Center and also the co-chair of the Grey-Bruce OHT Planning Committee. And if I just call on Mike here to introduce himself to everyone, please.
Good evening, everyone. Thanks for joining us tonight. I'm Mike Barrett. I'm the President and CEO for South Bruce Grey Health Center, which is the four-site hospital along the southern portion of Grey and Bruce counties. And I have the pleasure of being the co-chair of the Grey-Bruce OHT with Alex.
Great, thanks, Mike. So we've got a few formalities before we get into the information session tonight. Now, first of all, I want to say a big thank you for attending and expressing interest to learn a little bit more about our health system here in Grey and Bruce. My role tonight is to open the session and hand it over to Steph Dudgeon, who I'm going to introduce in just a couple of minutes. And then at the end of the session, Mike is going to do a wrap up and close for us. So just a couple of housekeeping items before we get underway. And I think most people are used to this these days with a lot of Zooming, but please keep your microphones on mute unless you've got a question or a comment to make. So just click on the microphone in the control panel on the bottom of your screen, and you can just find the screen by hovering towards the bottom of it with your mouse, and you'll see the mute on the left-hand side. If you're joining by telephone, use *6 to mute and unmute your microphone. And to connect your video, if you've got enough bandwidth, and I know that's an issue sometimes, you can click the Start Video in the control panel right beside where the mute button is, again, by hovering at the bottom portion of your screen. Don't hesitate to use the chat feature in the control panel to ask questions. It's kind of in the middle there. Again, when you hover towards the bottom of the screen with your mouse, you'll see chat right in the middle. Just click on it and it'll pull it up. And to be respectful for all participants as well as the presenters, if you could please remain on mute unless you have a question during the Q&A period at the end of the session. And this meeting is being recorded and will be available on our website. And if you are not comfortable being recorded, don't hesitate to turn your camera off. Okay, Abigail, next slide, please. Great, so that's our agenda for this evening. We've got a couple of really interesting topics and really looking forward to sharing all that information out. And so I'm going to take a few minutes to talk about the purpose of these information series and give a quick update from an OHT perspective. Then we'll turn it over to Steph to introduce our presenters. And then, as I mentioned earlier, Mike will close it off and facilitate the Q&A portion of our evening. Next slide, please. It's really important to acknowledge that the work that we do with the Grey-Bruce OHT and all our members take place on the traditional territories of the Anishinaabe nations, known as Ojibwe, Ottawa, and Potawatomi nations, who've lived on these lands for time immemorial. The land that we call Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. and it continues to be the home to many Indigenous people who live alongside settlers, newcomers, and people whose ancestors were enslaved across the Americas and the Caribbean. We are very grateful to live and work on this land, and recognizing this aspect in a meaningful way means making commitments to sharing and upholding responsibilities to all who now live on these lands and the land itself. And in our work, let us be mindful of these commitments. Next slide, please. So again, welcome to the session tonight. I've introduced myself and Mike, and I'll just take a minute here to introduce Steph Dudgeon. Steph, if you just want to take a wave and introduce yourself to everyone tonight.
Hi, I'm Steph Dudgeon, and I'm with the Brockton area Family Health Team, and I am also the chair of the Grey-Bruce OHT Engagement Sub-Committee. So nice to see everyone on the call tonight.
Thanks, Steph. We're very lucky. We got a really strong engagement subcommittee, and you can see great membership from a number of different health system partners across Grey-Bruce, and they're just doing a terrific job helping us on our journey as we form an OHT. Engagement with stakeholders is very important, and with the community in particular, this whole initiative was all intended to focus on making improvements to our population at large. And so the work that this committee is doing is extraordinarily important. Next slide, please. So the purpose of these sessions, and this started back in March based on a request where people said, we really don't know what our health system is all about. And it is a very large system, and it has a lot of different providers, all doing great work here in Grey-Bruce. And based on that request, we thought it was really important to provide a series of information sessions to engage with the community, and importantly, increase everybody's awareness in terms of what is the health system in Grey-Bruce all about. And so that's really providing members of the public with more information about our system. And hopefully, when the sessions conclude, everyone will have sort of a good perspective of what the whole system is all about, so that when we begin introducing changes through our OHT, they'll kind of make sense in terms of how those changes will ripple across the different health service provider organizations. Next slide, please. So an Ontario Health Team is really a new way of organizing and delivering care. It's not about creating a building or consolidating everybody into a building or a structure. It's really all about organizing and delivering care in a way that's more connected to patients and local communities. And so under, as you can see on the slide, under Ontario Health Teams, healthcare providers, which really includes all the players, work as one coordinated team, no matter where they provide care. There's a lot of work to do that because we tend to operate in silos, and technology is a big enabler in terms of being able to work as a coordinated team. And today we've got a lot of different technology systems that don't talk to each other. So there's quite a bit of work to do, and we're going to get started. And that's what really tonight is all about, is beginning that start process. Next slide, please. So the health system transformation in Ontario is enabled by some legislation, which has basically created a new agency called Ontario Health, and also is allowing for the establishment of Ontario Health Teams. And I won't go sort of through the details of the legislation, but the picture at the bottom of this screen is really what the strong message here is that presently patients relate to the health system separately with organizations and providers within the system. Under an OHT, it's one entity made up of a number of organizations under that umbrella, and so that a patient can receive healthcare that is a lot more coordinated under that umbrella rather than through a siloed type of approach. Next slide, please. And so the good news is we were officially approved September 17th. I know there's been a lot of talk about OHT in the last year and a half or 2 years, and a ton of work has being contributed by all the health service provider organizations across Grey-Bruce to get us to where we are today, which is at that approval stage. That being said, we've got a lot of work to do to set up our organization structure, to identify the projects that we're going to work on, and begin the process of forming a team. So really the approval is just is really the start line of a journey. And it doesn't mean that we're operating as a well-functioning OHT today, because we're not. We're 6 weeks old, 5 or 6 weeks old, and we've got a lot of work to do yet. Next slide. And so we've got a number of initiatives underway, and you can see sort of the planning committee that Mike and I chair. We've got strong membership and representation throughout Grey-Bruce. We have a number of subcommittees, collaborative decision-making arrangement subcommittee. It's a lot of words to describe basically a committee that's focused on figuring out how we're going to work together, how we're going to make decisions, what do we do if we have disagreements, how do we pick our priorities, and that type of thing. And then documenting that in a way that we've got a touch base so that we can go back to it in the event that there was ever a misunderstanding or a dispute, that type of thing. The engagement subcommittee, which I talked to a few moments ago. We also have a physician and nurse practitioner council. Very, very important to have engagement from our primary care health service providers, and physicians and nurse practitioners are extremely important. And we're very, very lucky to have a high level of engagement from them. And we just recently learned from talking around other parts of the province, this is a particular strength for our OHT as we begin the formation process. We're very, very lucky to have physicians and nurse practitioners that want to invest their time and energy in forming this team. We've also got a chairs council that's in the process of being formed, and a community council that has been formed. We've got representation from all across Grey-Bruce, and a number of you are here tonight. I've recognized a few of the names, and that community council is really the basically playing the role of a patient advocate to say, as we're doing this work, let's make sure that we bear the patient in mind and the patient's perspective in mind, and that's really representing the voice of the patient. A lot of interest in this council. We had a lot of applicants when we were forming it. We went through quite a rigorous selection process, and we've got just an absolutely very, very strong community council, and that's going to really help us a lot going forward. Next slide, please. So our year one focus population, so it's really about beginning the process to form our OHT. And we need to be very thoughtful and selective around where is our first focus going to be as we start to identify opportunities for improvement and implementation of change. And so for us, we chose frail seniors with a focus on transitions in care and patients and clients living with mental health and addictions issues. And that was based on sort of a broad perspective from health service provider organizations across Grey-Bruce when we were having the early conversations around where do we need to focus. And we asked the community at large, do you support the planning committee's choice for the year one priority? And you can see overwhelmingly there was support for that focused choice for that year one. And the full survey results can be found on our website. Next slide, please. Okay, and at this stage, I've finished my duties almost, and I'm going to turn it over to Steph to introduce our first speaker tonight. So over to you, Steph.
Okay, thanks, Alex. So I'm happy to first introduce you to Kevin McNab, who is the Director of Paramedicine Services with the County of Grey, and Steve Schauss, who is the Director and Chief of Paramedicine Services with the Corporation of the County of Bruce. I think that you'll find that paramedicine services has really evolved, and they are part of some really exciting initiatives that you may or may not be aware of, but certainly very much touch our two priority populations of the Grey-Bruce OHT. So I will hand it over to Kevin and Steve.
Hi, I'm Steve Schauss. I'm going to take over for the first part of the presentation, and then Kevin's going to jump in and do some of the gray stuff, and then he's actually going to do the community paramedicine side.
Good evening, everybody. Thanks for having us here tonight. Looking forward to this presentation.
Okay. So, yeah, so there's Bruce County Paramedic Services and Grey County, and we're provincially regulation, Ministry of Health, Emergency Health Services branch. We're 50-50 funded through the municipality and the province, and our community paramedicine program is 100% funded through the province. Next slide. So on the Bruce County side, we have 7 bases: Walkerton, Chesley, Kincardine, Port Alban, Sauble Beach, Wyatt, and Tobermory. Paramedic staff's broken into 62 full-time, 46 part-time. We have 7 management staff, 3 senior managers, and then 4 shift superintendents. We have a fleet of 12 ambulances and 3 ERVs. For 2020, we did 7,155 patient carrying calls. And then in Grey County, they've got 8 bases. I just gotta, there we go. So they've got 8 bases: Owen Sound, Markdale, Meaford, Craigleith, Markdale, Dundalk, Durham, Hanover, Chatsworth. They have a staff of 82 full-time, 55 part-time, management staff of 8, 15 ambulances, 8 ERVs, and the patient carrying calls 11,397 in 2020. Next slide. So our role and function, providing emergency and non-emergency patient care in the community, responding to 911 emergency calls, non-emergency transfers, non-emergency community care and prevention, so community paramedic program, public access defibrillation, and special event coverage. Next slide, please. Kevin's going to jump in and talk about Grey County and their stats.
Yeah, so for as far as what we're measured on and what we're required for under legislation, each municipality, each year we have to develop a response time performance plan. And then each year we report on it yearly of the results. So the first one is our ability to respond to sudden cardiac arrest. The ministry sets the time of 6 minutes, and then the municipality sets the percentage, which is for Grey is 40%. For CTAS 1, and the next response times are broken down what we call CTAS, or the Canadian Triage Acuity Scale. And it's really defines really the need and priority for care of the patient. CTAS 1 being the most urgent, with CTAS 5 being the less urgent. So CTAS 1, which is a resuscitation, somebody with a major trauma or shock, our response time is set by the ministry at 8 minutes, and the municipality, we set it at 60%. CTAS 2, which would be like a chest pain call, or what we call an emergent call. It's for Grey County, it's 15 minutes, 90% of the time. For a CTAS 3 call, which we would consider an urgent call, that response time is 20 minutes, 90% of the time. For CTAS 4 call, which is a less urgent call yet, 20 minutes, 90% of the time. And our CTAS 5, which would be a non-urgent call, would be 20 minutes, 90% of the time. And when you think about the size of Bruce and Grey County, well, that's one of our biggest challenges is around the area. That this is not just a time from when we start to drive, it's a time that's measured from the time the pager goes off, the crew gets in the vehicle, finds the location, gets the crew details, and arrives at the scene. So I'll just leave it to Steve for the Bruce County.
So in Bruce County, our sudden cardiac arrest time is set at 6 minutes, and you see it's our target's 30%, due because of the rural proximity of our calls. That's why it's really difficult to reach them in less than 6 minutes. CTAS 1, it's set at 8 minutes or less, and it's 45%. CTAS 2, 15 minutes or less at 50, 20 minutes at 70. For CTOS 3, CTOS 4, it's 20 minutes, 85%, and CTOS 5, it's set at 25 minutes or less, and that's 90%. So that's our stats for Bruce County. And then we have our primary care paramedics. That's what we are in Grey and Bruce. So the primary care paramedic is a college graduate program dedicated to the paramedic profession. The diploma in paramedic studies is generally 2 years in duration, emphasizes anatomy, physiology, pharmacology, and mechanisms involved in acute injury and an illness. The program involved classroom learning and clinical hours working directly in the field. Once the college program is successfully completed, the paramedic must complete a provincial examination. This certification, known as paramedic exam or advanced emergency care assistant, AMCA exam, must be successfully completed to practice as a primary care paramedic in Ontario. In addition, each PCP must complete many continuing medical education courses on an annual basis to maintain their qualifications. The PCP is also certified by a physician to perform several controlled medical acts for individuals experiencing acute injury or illness. And our base hospital is, we have a base hospital dock in Owen Sound. Next slide, please. So the primary care paramedic skill set, it's quite extensive and it's grown over the years, quite a bit since I first started as a paramedic. So emergency patient care, CPR, patient immobilization, oxygen therapy, basic trauma life support, blood glucose testing, SpO2 monitoring, carbon monoxide monitoring, lead 2 interpretation, 12 lead ECG application, interpretation, and STEMI diagnosis, monitor intravenous line, IV with normal saline, thiamine multivitamin preparations, and potassium chloride, initiation of intravenous like and fluid therapy for paramedics certified, taser probe removal, emergency disconnect for home dialysis, code stroke bypass to stroke centers, continuous positive airway pressure, CPAP, supraglottic airway, tracheostomy reinsertion, suctioning and care, emergency childbirth procedures, Valsalva maneuver. And then our PCP skill set includes all these medications. So Tylenol, Advil, Toradol, ASA, Gravol, Benadryl, epinephrine, glucagon, Narcan, nitroglycerin spray, Ventolin, and 50% dextrose IV. And then medications currently under review. We're anticipating these in the next year or so. Opiate for pain, benzodiazepine for seizures, and a medication for sedation. Next slide, please. I think Kevin's going to take the community paramedicine side here.
Thanks, Steve. So just a bit of information on our community paramedic program. We've been working at this now since about 2009, but most of our programming started in 2015. But the first, really the grassroots of our community paramedic program is working with our partners in paramedic referral. So our paramedics, they screen patients over 65, or elders that are at risk in the community. And if they are determined with our screening tool, we offer referral out to home and community care support services. It's all done digitally, electronically when we do our electronic patient record. We also have relationships with 211 Community Connections for social economic support. So if people require further supports in their home, paramedics can refer to them. We also have the ability to refer to the Rapid Access Addiction Medicine Clinic in Owen Sound. So a few different referrals for us. The next one, and I'll talk more about this one on its own because it's the largest part of our program, is our home visit program. So I won't spend too much time there right now. The next one is community clinics. We go into county housing buildings, doing general health assessments, working with community partners Each week we go into the buildings, and typically the patients are over 65 years old, and we do vital signs assessment, general health teaching. We do falls assessments, and again, just working with our partners to determine if there's any gaps or any needs in their care. The next one, community outreach. We've been working at this through COVID. This is typically around the homeless transient population, people with addictions and mental health concerns. We work with community partners in the community to just do general health assessments, treatments, and a multitude of other care for them in the community. Through the COVID response, we've done a number of things, mostly around COVID-19 testing in outbreak areas. We would go into people's homes and test people, or in larger group settings, work there doing testing. We did just general health assessments and care for people in their home that were suffering from COVID. And from there, we also did work around vaccine clinics, working with public health through all these programs. We also work with the CMHA, the urgent response team, for when there are behavioral emergencies in the community. When these calls come in, the urgent response team, they respond with us. Next slide. So the community paramedic program, we've been fortunate to be able to do this since 2015. And just recently in this year, we were approved to expand our program. And Bruce County, great news, they're moving ahead as well with their program. But what we do is we take paramedics and we give them additional training, which greatly allows them to do an expanded scope of care, working mostly through the patient's family physician. We typically look at patients with chronic disease like chronic obstructive pulmonary disease, congestive heart failure, diabetes, people that have been to the hospital multiple times and emerged and been admitted to the hospital. The whole idea of the program is to see these people 2 or 3 days before the emergency happens. And we go out and assess them in their home, and then working through their primary care provider, determine with the physician a treatment plan, which could include antibiotics. It could be different medications for heart failure. From there, it could be, if their insulin level, adjusting that if their sugars are off, and again, through this, either through the physician or the nurse practitioner. There's a number of different assessments we could do. We're able to do blood work and get analysis of their blood right on the scene. We call it point of care assessment. We can do flu shots in the home, and we also did a number of homebound COVID-19 vaccines. Through the pandemic, the other initiative that we have done is we've started working with the palliative care physicians of Grey-Bruce, and also the home and community care support services palliative care team there. And we're required to go into the home and do palliative symptom management and care, again, under the direction of the physician. So we have a unique opportunity. We go into the home, we observe them in the home, and we feed that information back to the physicians. We remain available for what we call exacerbations if people get sick, but also we see people on a routine basis as a general health assessment checkup at a minimum, at a minimum of every 3 months. Very fortunate to work with the primary care providers. They enable us to do what we do today. We're able to go out and assess them and give that feedback to the physician in their medical record, which I think helps really bring that information right to the physician, help them make decisions. Next slide, please. Just around service opportunities and challenges. Each year over year, other than last year, we were under our normal call volumes last year, but on average, we have at least a 4% increase. And there was a period there for Grey County, we had over a 20% increase in 3 years. So call volume seems to keep increasing. So that's one thing that we're always monitoring and adjusting for, is increasing call volumes. Weather here is an issue as far as response times and getting to calls. So that's presents a challenge to us. And again, it's the large geographic area that we have to cover. And another issue that we have right now is, and it has been ongoing, but definitely more attention to right now, is our work around preventing of operational stress and PTSD, and working with our paramedics in that field and keeping them as healthy as possible. Opportunities, we really feel that our biggest opportunity is to reach out and work with our community partners. Community paramedicine has really brought that to the forefront for us. We've become part of a team working with our community partners and really enjoy doing that. And that speaks to also with the work we're doing around health outreach, with the health outreach that we're doing in the community with our different partners. And just recently, we're looking at new models of care. The palliative work that we do in our community program, there's an opportunity now to do that same type of palliative work in our 911 system. So that's covered 24/7 across the county with our 911 or emergency paramedics. And also opportunities for alternate destination. And one would be direct transport to a hospice as opposed to having to transport to a hospital first and then to a hospice. So some interesting new models of care that are becoming available, and that we're working over that over the next 1 to 2 years. Next slide. And this is just our contact information. If there's any questions, you can feel free to reach out.
Okay, thank you, Kevin and Steve. So we thought we would try a bit different format tonight than we have in the 2 previous sessions, where we would take questions after each sector presentation. And then, of course, we will take questions at the end. But if anyone has sort of any immediate questions for Steve or Kevin about the paramedicine services, we would be happy to have them answer them right now. And it looks like we can start with one in the chat box from Alex, wondering what EVR stands for.
I think he's probably ERV, it'd be the emergency response vehicle.
Okay.
So typically we have 2 types of vehicles. It's one's the ambulance for transport, but an ERV would be somebody that's a single paramedic, like a supervisor or a community paramedic. But we also have paramedics that are emergency first response paramedics who will go there and treat you, and then an ambulance will show up and transport. And the whole idea is to get healthcare to you as quickly as possible.
Okay, great. Another question is, how do you get referrals for the home visit program?
So like for the home visit program right now, we've been taking most of our referrals through the home and community care support services or directly from physicians. So if you have a family physician, you can ask them about referring through there, or you can call the number on that was provided there, and we will connect you with the supervisor in charge of taking referrals.
Okay, and another question is, are you finding that there are higher levels of complexity in patients living in the community, especially seniors?
I would say yes. It's getting more and more. They're staying in the homes longer. Yeah, that I would definitely. I would say that.
I would say that people want to be treated in their home and stay in their home. So we do see people with complex medical conditions living in their home, and and that's one thing. Again, we're just one part of the team, but that's where working with the team or community paramedics, working with those people that are more complex and more at risk of going to emerge and being admitted to the hospital. That's really we actually spend most of our time in that area.
Okay, and I see a hand up, but first I just noticed that I missed a question in the chat box that I want to circle back to. So with the home visit program, what about residents without a primary care physician or nurse practitioner? Are they able to be referred into the program?
Yes, we with the CPLTC or Community Paramedic Long-Term Care, this is the new funding. We will accept all patients that that are seniors at risk in their home. So the best place for that is to go through just calling that number and putting your name forward, and then we'll have go through like some questions and follow up as far as taking that patient on.
Okay, that's great. So I see a hand up from Sasson.
Hi, everyone.
Hello.
That data. I noticed in your statistic, you provided the 2020, all the calls, volume, and stat. I was just wondering, do you have any data for the last 5 years in terms of trends? You know, in the last 5 years, or what was the increase, so we can have some kind of idea if it's almost the same, increased, or plateaued, something like that. And the second part is, do you have a projection for the next 5 years? Like, what do you think about next 5 years? How are the calls going?
I would say in Bruce County, just like in Grey, over the last 5 years, other than last year with COVID, it really, you know, our call volumes dropped for a little bit. But when people, I guess last year, over the summer, our call volume actually went increased over the year before. And so the last 5 years, we were in the probably 3 to 3.5% increase in call volume every year for the last 5 years. And we anticipate that to continue just because COVID's changed everybody's, the way they, we're finding that everybody's leaving the GTA. They're coming up here, as you can see by all of our subdivisions and all over Grey and Bruce are really expanding. So we're fully anticipating our call volumes to get even higher than they have been in the last 5.
Thank you. I have a follow-up question also. There was a pilot program that offered to paramedics in terms of the daily palliative care, that the patient could stay at home and you do a wellness check. There were some communities picked up in Ontario and paramedics were providing that services. I was wondering where you get approached to do that kind of services, or what's the status for our Grey-Bruce counties?
I'll let Kevin answer that. We do that both in Grey and Bruce, but he can expand on it a little bit more.
Yeah, there's a couple of things to that. The first one is that we're already working with the palliative physicians and the palliative care team with palliative patients in the community, with our community paramedics. So at the request of the physician, we'll go out and do assessments and care in the home around palliative care. So we have medications for pain and breathing and delirium and secretions, more or less based upon a symptom relief kit that would be in the home for a palliative patient. And then just this past August, the work that we did through this palliative initiative in Grey-Bruce and in other municipalities, a lot of it stemmed through COVID. We put a proposal together for the Southwest region, so pretty much from Grey right to London, that was approved by the ministry, where we would do in the home palliative care, not just in our community paramedic program, but also in our 911 side. So if somebody were to call an ambulance at 3 a.m, the paramedics arriving would have some element of care for a palliative patient. And if the goal of the care was to stay in the home and working with the physician and the nurse team, that we'd be able to offer some symptom management at that time. Or if the plan was to transport directly to the hospice, that we would be able to do that and not have to go to the hospital first, to keep the patient most comfortable to be able to do that. So there was some programs that were approved and they've already started. I believe you're probably thinking about like Ottawa and York region, and these are similar models to that.
Okay, some really great questions. So there's one more, and then I think after it, we will move on in the interest of keeping on schedule. But just so everyone is aware, there will be a Q&A document posted when this session is posted. So any questions will definitely get answered and shared out to the group. So the last question is, have you identified any barriers or challenges in the home visit program?
For us right now, and probably one of our biggest challenges or barriers, paramedics, they work under the delegation or the direction of a physician or a nurse practitioner. So when we can have that relationship with a physician or nurse practitioner as a partnership in the home working as a team, they provide us the delegation. But I think one thing, and it's been new for us because since May, we've been able to take on additional patients. And again, we take on pretty much all patients that are at risk in the community, but some of these patients are unattached to primary care. And that is a problem for us because the advanced directives that we're able to use really under a physician or nurse practitioner, we're unable to use them. So what happens is we can go out and do a general health assessment and referral and some care in the home, but ultimately for those patients, the only place for us to go with them is emerge. So care that we would normally do when we have the ability to work with the rest of the team, we are unable to do that. So again, it's not perfect, but again, that's one of the barriers that we're working on trying to find a resolution for that, but we haven't been able to determine it yet.
Well, and certainly highlights a bigger problem that we, are looking to address across the province with access to primary care providers. So, okay, thank you very much, Steve and Kevin. And again, there'll be another opportunity for questions at the end of this session if anyone thinks of something that they would like to ask of these two gentlemen. But we will move on now to the palliative care component of tonight's session. We have Liz Laird, who's with the Southwest Palliative Pain and Symptom Management Consultation Program, and Janet Fairbridge, who's with Residential Hospice of Grey-Bruce, presenting tonight.
Thank you, Steph, and thank you everybody for the opportunity to share something that we're very passionate about, both Janet and I, in our daily lives. As Steph already mentioned, we will share the information, and how about if we just get started, Steph, if we move on to the next slide. Thank you. Before we start, we really wanted to just mention that what we're sharing is really it's a compilation of services that are focused in hospice palliative care, but for palliative care across our counties, primary care is the base for most people. So we want to acknowledge that palliative care also happens within family health teams, community health centers, the Southern Ontario Aboriginal Health Centre, all those settings that people interact with, the hospital, services in the home. It really takes a village, and we can't say enough about everybody's role in palliative care. And a really good example is actually what Kevin just shared in how EMS services have the paramedic program have really added to palliative care in the past year and a bit. It's been a welcome addition. So we thought we'd start with sort of a shared understanding of how we talk about hospice palliative care. And it's really a focus of care that's aimed at relieving the suffering and improving the quality of living of people and their families who are living with or dying from a life-threatening or life-limiting illness. And this is across any setting. The goal of palliative care is to provide care and comfort with the associated symptoms and the impact of the illness experience and symptoms. So not just physical, but social, psychological, spiritual, practical. As I already mentioned, within Grey-Bruce, there are a number of organizations and services that are supporting palliative and end-of-life care on through to bereavement. These services that we'll share tonight will include the volunteer visiting, caregiver supports, grief and bereavement supports, those supports one can get in the home, hospice care at end of life, the people that we have in our communities, such as the physicians with that secondary level of expertise in palliative care, and how that all works together. So you want to go to the next one? Thank you.
As Liz said, volunteer visiting and caregiver support programs are very much a key support and a key piece in good palliative care. And we're very fortunate in Grey-Bruce to have a number of different organizations who help provide those kinds of services. The volunteer visiting is provided through Bruce Peninsula Hospice, and also the supportive care program, Grey-Bruce, the VON. Through these programs, trained volunteers are matched with their patients and families to provide the support through companionship, respite, legacy work, and emotional support. And then also additionally, caregiver support groups, caregiver seminars and education opportunities, as well as lots of different print and virtual resources that are able to be shared. In terms of the funding structure, the VON supportive care is funded through Ontario Health, as well as they do accept donations and rely on donations from the community. They have 3 staff in their supportive care program: their coordinator, bereavement support coordinator, as well as administration support, and then also heavily rely on volunteers. At the Bruce Peninsula Hospice, they are 100% funded by donations and grants. They do have 1 staff person plus numerous volunteers for visiting and fundraising and the committee work. We don't have the actual budget numbers for these programs, but would encourage you to reach out to the providers directly for that kind of information. We can go to the next slide, please.
And so this is a very busy slide, and so we don't expect everybody to read all that's listed there. Home and community support services have and are very integral piece to the kind of support for people that are in their home, in retirement homes, nursing clinics, and home and community care provides a number of supports to all folks that are on their service. You know, such as nursing, personal support workers, those allied health therapists such as physio, occupational, respiratory, dietary, speech language, and social work. They're also a gateway and help with referrals to various services. They're a good source for information and access to various programs. For palliative care specific, the complex care coordinators are generally registered nurses and that have additional palliative care experience and education. And they assist by providing assessment, system navigation, supporting goals of care conversations, application eligibility for hospice. Those are the kinds of things that the care coordinators help to facilitate and navigate for folks. And Kevin also mentioned this about the palliative care specific team. So there are nurse practitioners that have additional knowledge and expertise in palliative care, and they have a position too here in Grey and Bruce counties, palliative nurse liaison. And those provide support to care coordinators and the visiting nurses with people who are at home receiving palliative care. And we have a spiritual care team that helps with psychosocial, spiritual conversations and support for patients and families in the home. So essentially, those complex care coordinators help to establish care plans, access to services based on a patient's wishes and needs, so they can receive the care that they need in their preferred location of care through their illness journey on to end of life. Next slide. Actually, I will just mention as well, because it wasn't on the slide, and I apologize. One of the supports that home and community care support services can offer is the hospice at home. And so this is an opportunity that can allow for overnight support for families caring for family members And it's delivered by a PSW personal support worker who can do a shift overnight in the home. And they're supported throughout the night virtually with an RN. And the focus is on, personal care and symptoms to allow the family to rest. And this is one of the palliative care focused services that the complex care coordinators can help people access. The next slide.
So in terms of palliative care in hospices at end of life, again, in Grey-Bruce, we're fortunate to have 2 facilities currently. Residential Hospice of Grey-Bruce, for whom I work for, who operates Chapman House. And we are an 8-bed community hospice with a wonderful multidisciplinary team who provide compassionate, person-centered palliative care at end of life. And I think it's important to note as well that good palliative care is person-centered, but it also wraps its arms around the family unit of that individual, of the person at the center, in whatever form that family unit might take. So at Chapman House, resident and family care is provided by our team of nurses, personal support workers, our palliative care physicians, our spiritual care providers. We have a wonderful team in our kitchen, our maintenance and fundraising and administration staff. Chapman House is very much deeply supported through our volunteers in every area of our home. The ministry, the province provides funding for our nursing and PSW teams. The portion is covered by them, but all other aspects of our care, the building, the supplies, the food, that relies heavily on donations. In fact, it's over 50% of our overall operating budget is relying on those donations. And of course, there is no cost to the patient or families that we serve. Also in our community is the Huron Shores Hospice, who share a space at Tiverton Park Manor. They are a 2-bed community hospice providing end-of-life care. And respite is what it should have said, although respect, of course, goes hand in hand with that care, but that is provided to area residents and their families as well. Resident care is provided with the support of volunteers, nursing, and PSWs from the Tiverton Park Manor and the palliative care physician in the area. And they're also very fortunate to benefit from the services of end-of-life doulas as well. When it first got started, they were 100% funded through community donations and fundraising. And Ontario Health now does provide some funding for nursing and PSWs. That has recently come into play. And of course, it should be mentioned as well that there has been a great deal of work going on to establish a hospice in the southern part of Bruce County. Of course, the pandemic has had significant impact on that very important work. And there will be more information on that as time goes on. And next slide, please. So we mentioned how palliative care really does wrap its arms around both the patient at the center, but equally so the families and friends around that person. And that's where grief and bereavement supports come into play. Through Residential Hospice of Grey-Bruce, we have a number of community programs. Conversation Cafe, which is a 6-week program once a week, where our bereavement team is able to help support those seeking bereavement help. Grief support, of course, group and one-on-one opportunities are available. We have a great volunteer team who provides bereavement support phone calls, which of course have been very key, particularly through the pandemic. We also provide celebration of life services, and we are staffed, these programs are all staffed by spiritual care providers and trained volunteers, and all of these programs are 100% funded by community donations. Equally so with the community programs at Huron Shores Hospice. They have grief recovery method sessions, they host death cafes, they also provide end-of-life planning workshops, and all of these, again, supported by trained volunteers and 100% funded through grants and through donations. At the VON, their bereavement services, they have grief and bereavement groups, one-on-one and home visits. They provide numerous different print and virtual resources that are available to be shared, and they are supported by both staff and trained volunteers, and their funding does come through the Ministry of Health as well as community donations. And last but certainly not least, Bruce Peninsula Hospice providing their bereavement services through individual contacts and visits. They also have group sessions and access to numerous resources, again supported with trained volunteers and staff and funded through donations and grants. Our next slide, please.
So in addition to these supports that are there for patients and families, there are supports here in Grey-Bruce for healthcare providers. So we have a 6-physician consulting group. So it's a community palliative care physician consulting group. And these are physicians with additional expertise and focus in their practice on palliative care that are there to support those primary care providers and their patients in delivering effective and quality palliative care and that ever important symptom management piece. This physician group works in the community, in hospice. They're connected with the oncology unit and the outpatient clinic, all the community hospitals. And what they provide is consultation level support and on-call services for primary care providers. The funding for this currently is primarily through physician billing for these 6 physicians. The other program that's out there is the one that I work for, which is the Southwest Palliative Pain and Symptom Management Consultation Program. And there is one of me here in Grey-Bruce, and I work with healthcare providers as well. Nursing, physician, all providers through sort of a 3-pronged approach. And consultation is one of the things that, that I do, education and system development and advocacy, and do this across the continuum of care that we have out there: long-term care, hospital, community, hospice. It's one of the very enjoyable parts of my role is how diverse it is and how many places I can have contact with and support. And so my primary role is really to build the capacity of those healthcare providers and service providers, again, to look at quality hospice palliative care. This program is funded through the Ministry of Health, Ontario Health, and is hosted through St. Joseph's Healthcare in London. So sometimes there's confusion when people see my contact information that I'm in London, but I'm here in Grey-Bruce between Dornoch and Chesley, actually. Next slide. So, you know, as we've shared, there's a lot of services and organizations that are, you know, palliative care is part of what they do, that have also focus with palliative care. And the good news is we talk to each other. We talk to each other and communicate with each other a lot. So here within Grey-Bruce, there is the Hospice Palliative Care Collaborative Table. We are a local subcommittee that's accountable to the Southwest Hospice Palliative Care Network Leadership Committee. And there's a table, there's a collaborative table in each of the areas here in the Southwest, like our local table. The purpose of this collaborative table is to provide leadership and expertise, again, to enable and advance high quality palliative care across our region. We are influenced in our work by provincial and regional standards to meet the local needs. And it is this partnership, as mentioned, with a mix of leadership, clinical, and subject matter expertise at the table, and representing different sectors and roles. The table is also going to be looking and reaching out at some point in the near future to grow to add patient and caregiver voices also in on the collaborative. I already mentioned that, you know, hospitals, long-term care, community, spiritual care, supportive care, hospice, palliative care services and supports, home and community care services and supports. This is the mixture that is present at the table at this time. And as I said, we meet monthly. We work on priorities. We work to support projects and initiatives related to palliative care. And we share with each other gaps and needs that we see, and look to see how we can help to fill those or meet those needs. Next slide.
So healthcare, of course, is famous for all kinds of acronyms. So we tried to not use too many of them, but to make sure we could get all the information on one slide, there are a few on that page. So do forgive us on that. So here is how you can connect to any of the individual programs that we've mentioned. There are several points of entry, as you can see. Direct contact, talk to your practitioner to help to connect you to and through home and community care support services. And we'd like to say that there really is, no door is the wrong door. If you reach out to any one of these providers, and if they are not quite the right fit for the needs that you have, they will help direct you to make sure you get the right care at the right time in the right place. So we encourage you to reach out to any one of these providers right across our counties. For the healthcare providers, the physician group and Liz's program, the Palliative Pain and Symptom Management Consultation program, are there to support you as well. So we encourage those local healthcare providers to reach out as well.
And next slide. So we've whittled down the opportunities and challenges to several, just a couple of bullets under each. Opportunities, we see wonderful opportunities to work together and see absolutely the advance of an Ontario health team here in Grey-Bruce as part of that, creating that continuum of care and support for the person and their family along their entire illness journey. And as Janet said, no wrong door to enter in on. We also see an opportunity to begin to embed a palliative care approach throughout the illness experience. So starting earlier, palliative care can be a part of the supports and services for folks, from diagnosis through to bereavement. And we see opportunities to improve a palliative care approach across primary care, across all settings of care earlier. The challenges that have remained is, the knowledge base and skill in palliative care, again, across all sectors and disciplines, along with the human health resources, which I believe, Steph, you've mentioned, and I'm pretty sure you have probably heard that more than a few times, the impact that is having on what we are doing. And I think if you move that forward, Steph, yeah, opportunities for questions, and I do see one already in chat.
Perfect. So thank you so much, Liz and Janet. I am always, I know that we are working in an imperfect system and there's lots of room for improvement, and that's why the OHT is so important, but I am always impressed by the tremendous work that is being done in Grey-Bruce, and these presentations always highlight that for me. We have access to so many excellent services, and just, I think, like a really tremendous commitment from organizations and providers to offering, all that we can to this region. So thank you for your presentations tonight. I certainly learned a lot. So we do have time for questions. So the first question in the chat box is, are you and your team able to work with Saugeen First Nations palliative needs as well?
And I can start this off, Janet. If you have anything to add, feel free. The short answer, Richard, is absolutely yes. Have done work with the First Nation community a few times. We've provided or supported or worked with on different education pieces previously, consultations, lots of conversation about, if we can provide resources and supports for initiatives that the community is looking into. And yes, would be the very short answer in that. And Janet, would you have anything to add?
I would just add an additional big yes. Most definitely, we are here to serve everyone in the Grey and Bruce counties, and so we would encourage and welcome that at any opportunity.
Sorry, I'll unmute myself. Is there help or planning if people choose medical assisted death?
There is. It's medical assistance in dying is not directly connected to palliative care. People choosing medical assistance death still may have palliative care, absolutely, up to the moment of that being initiated. But with home and community support services, there is a navigator around medical assistance in dying. And we have a number of physicians and nurse practitioners who will do the assessment pieces, as well as provide at the moment that the person has chosen for their death and medical assistance. So there absolutely is help. There is also opportunities for if people are looking for education, and healthcare providers are obliged to assist people to connect with the services and the supports to enable them to have this choice, no matter who they are and where they are, or how a healthcare provider may feel about it personally. And I don't know if that answers it totally, Richard, but that.
So then this next question ties into that, and I might be interpreting this wrong, so whoever wrote it can certainly correct me, but has there been any discussion locally around MAID or medical assistance in death entering into the future as a choice in palliative care? So I'm wondering if that is meant to be hospice care, but I'm not sure about that.
I'll take that one.
Yeah.
To be able to say yes, discussions continue to be ongoing. We, as Liz indicated, as healthcare providers, do help facilitate those connections. Should someone be seeking education or seeking out that particular option, but the conversations continue to evolve, and certainly will continue to do so, especially around the legislation. But it continues to be a topic of discussion for us.
Okay, thank you. And then, does grief support include anticipatory grief support, for example, for family providing care for a family member with dementia?
Yes, through home and community support services, if there's supports and they're with the complex care coordinator, access to the spiritual care team, or access to the social worker. The other thing I would add to that is connections with the Alzheimer's Society. We also utilize those connections because they come with that particular expertise. There are caregiver support groups. So my mind is sort of running through all the possibilities, as you can tell, and I would say yes, and happy to help connect to something for folks around that. I did have a person once say to me, it was a daughter of someone who had dementia, and she defined dementia as the grief that keeps on giving. And it felt like a very appropriate decision of the constant, steady losses that the person and the family experiences. So yes, really critical support, I think, when we're supporting someone who has dementia in our family.
Okay, thanks, Liz. And then we have a hand raised, Sasson.
Hello, thank you so much for providing that information. In the beginning, Alex mentioned that we have so many great services, but they are silos. So the services, they don't talk to each other in terms of, again, data. As you know, I love data, so I like to see the data. So I was just wondering, what is our ranking or benchmarking against provincial standards or national standards? Or to clarify, how do you measure success in, in showing data in our region, like in terms of what is our waiting time, what is to staff to patient ratios, that kind of things? Thank you.
Do you want to start that off, Janet, just about the kinds of data that you collect?
Sure, I can, oh, sorry. Yeah, I thought,
no, go ahead, Alex.
No, you jump in. Absolutely. I can talk about it from sort of the OHT perspective,
No.
but I'll wait.
Yeah, no, go ahead. Go
Are you
ahead.
sure? Okay.
Yeah.
So it's a very good question. And there is a plethora of data available. And we're just beginning to get access to it from a regional perspective. We all have our own data sets within our own organizations, but getting a regional view is relatively new to us, and we'll be getting as, because we're just recently approved as an OHT, we'll be getting a regular flow of information from that perspective on an ongoing basis going forward. Our OHT has identified a number of measures of success, as well as the Ministry of Health identifying 3 mandatory measures of success. And they're related to things like ALC days, emergency department visits, and so on. And that information was just actually finalized this morning. We don't have any tracking of it, but we will have tracking of it going forward, as I mentioned earlier, in terms of the data sets that we're going to be getting from the ministry. I hope that answers. Mike, is there anything you want to share from your perspective on that?
No, Alison, I'm not sure if the question was specific to hospice palliative care, maybe. Was that, or was it OHT related?
Which I can jump in a little bit around the hospice palliative care statistics. We are responsible, as per our funding letter with the ministry. We are responsible for reporting every month to the Southwest LHIN on statistics around how many patients we have served, how many clients we have seen. At the moment, they're not sort of publicly published, but I am certainly always happy to answer those kinds of questions. Sasan, if you would like to reach out to me personally, I'd be happy to share some of those numbers if that's data that's of interest to you. But we are responsible for reporting on that to the ministry.
And I'll also share, Sasan, just that it has been much work provincially from the advisory body, the Ontario Palliative Care Network, which is an advisory body to Ontario Health and the ministry. And timing-wise, pretty well right around the time that pandemic began, it seems that reports were shared about the benchmarks that we should be using and the metrics that we should be using. And we expect to see different benchmarks and metrics being expected of all service providers as we're able to return to that, I believe. And then those should be available publicly as well when we get back to that work at looking at those metrics and benchmarks.
Thank you so much. The reason that I ask is, again, as a local resident of Grey-Bruce and also a clinical researcher, there are different initiatives in terms of assessment, feasibility and regional access. So there are so many opportunities that we are moving towards, bringing research and clinical trials to rural Ontario and our community. But in order to do that, we need to establish some data metrics and make it, share to all these pharmaceutical and sponsors, so they make it more attractive to bring all these opportunities back to our region. So that's why I'm definitely interested to get some of those data if it's feasible. Thank you.
And I really appreciate what you're saying, Susan. The other lens that they wanted to look at to improve the metrics beyond emergency visits or ALC is about the actual experience of patients and families. And that has been, a bit challenging to think about metrics that might demonstrate that. But that has been a focus. And Kelly has put into chat, Dr. Fenn has put into chat, the Health Quality Ontario Palliative Care Network Quality Standards document that you might be interested as well.
Yes, thank you so much. Again, patient-centric design of focusing on patient and what they need, and again, bringing the patient and the advocacy group, their families into the discussion as a stakeholder to understand what is their need and how we can address them. That's a big opportunity and challenge for everybody.
Yeah, absolutely.
Thank you.
Yeah, and as Liz mentioned as well, the collaborative table that has all of the palliative care healthcare providers who do meet on a regular basis. My understanding is that they are going to be reaching out, hopefully in the near future, around having some of those public voices join that table. So that might be something of interest to you as well, Sasson. So I would watch for more information coming from that group as well.
Okay, and Richard has a comment which actually ties into a question that I have. So his comment is that Janet mentions how many patients you reach. The paramedicine program should help the patients you are not reaching or hearing about. And my question was around capacity and resources in Grey-Bruce, and are we generally able to support people or accommodate people to die in their place of choosing?
I would like to say we're doing a decent job at that. There are challenges, obviously. The health human resource challenge that we are all in healthcare facing right now is certainly having impact on that. But that being said, I can tell you from our hospice perspective, at least, we have cared for 103 individuals since January 1st of 2021. In 8 beds, that's a lot of people and their families. So I think from our perspective, from our own hospice, we are doing everything we can within those 8 beds. But is there more for the region in terms of needs? Absolutely. And I think we would all like to see more beds available for palliative care, for end-of-life care in particular. And that's a soapbox maybe that I won't climb on any further tonight. But because the providers within both counties are working together more and more, and certainly with the structure of the OHT coming into place, where those partnerships and those that alignment is going to be very, very key. I think we'll see even more working together and less silos, I hope, and certainly to be able to address those things and work collaboratively together even more in the future.
Lots of opportunities. So I don't see any other questions. Mike, I might, maybe I'll hand it over to you for sort of wrap up.
Okay, great. Thanks, Steph. And first of all, a big thank you to all of you, all the participants tonight, for taking the time out of your night. I'm sure you've got other commitments with family and friends, and to take an hour and a half with us to learn about the healthcare system in Grey-Bruce is really appreciated. So Appreciate you doing that, and lots of great questions tonight. And what we did the last time, and Steph or Alex mentioned this, any of the questions we get tonight, we will provide some Q&A back as part of the session so that you can refer to it later or show your friends, and it will be posted on our Grey-Bruce OHT website. So look for that. Want to recognize, I see a lot of members from our community council around the table, so thank you for joining tonight, as well as some members from our Chairs Council Terms of Reference group. So thank you for joining in and learning more. We do intend to have another session. So this was session number 3. Session number 4 is going to be public health, and then our service provider organizations, which are the service provider organizations that provide home care across Grey-Bruce. And I think Jody Phillips, I saw was on here earlier. Yeah, Jody's still on there. So you'll get to hear from some of our service provider organizations. The date has not yet been set, but we'll do that in our next session. So watch for that. And finally, a big thank you to our presenters. So really interesting information. I learned stuff when they present. First of all, from our EMS partners, Kevin McNab, Steve Schauss. I can tell you these are top-notch guys, and we're lucky to have them in Grey-Bruce. I get the opportunity to interact with them in my day job here at the hospital, and I think that's the most interesting thing about all of this is that everyone is connected with everyone. So hospitals, primary care, hospice, palliative care, EMS, we all connect in some way, in some fashion. So it's important that we work closely together and remove any barriers that could become an obstacle for patient care across the 2 counties. So big thank you to Kevin and Steve. They've been wonderful supports for us here at the hospital, and they've been wonderful supports to other parts of the system. And some of the work that they talked about is, it's really what OHT work is working with other partners, and some of the community clinics that they spoke about, that's partners working together to provide care for the people here in Grey-Bruce. And then our second group of presenters, Liz and Janet on hospice palliative care, 2 great professionals who are really doing a great job on the hospice palliative care front. And again, we're lucky to have them here in Grey-Bruce. So with that, maybe I'll just give one more opportunity. Any comments or questions before we wrap up? And I'll just watch the chat box here if there's anything else. So not seeing any come in. So again, on behalf of the OHT Planning Committee, my co-chair Alex, who opened things up tonight, thanks very much again for joining us, and stay tuned for session number 4, and you'll learn some more about service provider organizations and public health. Have a good night.
Good night, everyone.
Good night. Thank you.